Hey guys, Woodruff here. So we are going into, I'm going to lose track of this. I think part four of the diabetes lecture, starting to talk about the acute crises. In the last video, we talked about hypo versus hyperglycemia. Now we're moving into DKA versus HHS. So these are like um, some very serious crises that can happen. Both of these are related to hot high blood glucose, and they can lead to a lot of problems. So we're going to start breaking down some of the little subtle differences between them, but kind of like the difference between type 1 and type 2 diabetes. The treatment is very similar for these. There's minor little differences. So we're not going to give you a patient and expect you to be like, is it DKA or is it HHS? Because there's some things that we could give you to help differentiate the two, but at the end of the day, we want you to see big picture. Like, overall, what's the problem here? What's the treatment? This is a part of my lecture series that's happening during the wonderful Texas ice storm of 2023 in February. So, like I've mentioned before, so far I've gotten lucky and I have not had any interruptions from my son, but it can always happen at any moment. So if you hear a sudden noise and I have to pause it, just remember this is life. So anyway, so let's talk about DKA. So DKA is something you're going to see very commonly, especially if you work ICU or ER. I mean, med surg and other places as well too. But usually when you guys get them, they're pretty fixed. So depending on where you work. But you're going to see this effectively in a lot of patients because this is like a crisis that happens when people's blood sugar gets way too high. So what's going on here is that there is too much sugar and or not enough insulin. This is something that happens really more often in type 1 diabetics. For it to happen in a type 2 diabetic, they would have to be at the point where their pancreas is literally is almost like a type 1 where they have not enough insulin, or are not, they're either making no insulin or not enough to sustain their body. So your body has to get to a very desperate point to get into a state of ketoacidosis, which we'll talk about here in a second. It has to be at the point where there's literally no insulin. And remember, with type 2 diabetes, most of the time they have insulin. It's a cell problem, not a lot of the times, not always, but a lot of times it's a cell problem. Um, but effectively, what's happening here is that the body just gets to a point where it's like, okay, listen, bro, like you're not giving me the energy, the sugar that I need in order to supply you with the energy that you need. So it's like, I am hungry. I need something to give these cells the energy that they need. So it starts to break down other things. So the first choice, of course, is it wants to break down carbohydrates. But if it doesn't have carbohydrates to break down, in order to do this, because again, it's not about, I know there's a ton of sugar in the bloodstream, but it's not in the cell where it needs to be. So the body is like, I am so hungry. So it starts to break down other macronutrients. And the one that it usually goes to next is fat. So it starts to break down fat. And when it breaks down fat, what happens is that there is a release of what's called ketones. Like when you break down fat, a byproduct of that is going to be what's called ketones. And ketones are acid. And so what happens is that my body is breaking down all of this fat in order to release these ketones. But as a result of doing that, I'm accumulating acid. So I end up in this state where I have a really high blood glucose. I've released all these ketones, which are full of acid. So I get into a state of acidosis. And then, like I mentioned before, because there is so much glucose in my blood, it starts leaching all the fluid from my cells. And so I am severely dehydrated. So here's the big problems. I'm dehydrated, my blood glucose is high, and I'm in a state of acidosis. And that's the real issue here with diabetic ketoacidosis. So like I mentioned, it usually happens in someone with type 1 diabetes. And a lot of times this is like their first time that they have type 1. They come to the hospital and they're in this crisis. They don't really know what's going on. And this is how they get diagnosed. Also, illness and infection. What happens is a lot of times patients stop taking their medicines. They either don't feel well enough to take their medicines, or they think, hey, I'm not eating. I don't need to take my medicine. And so just keep in mind, remember, one of the things that can lead to hyperglycemia is going to be illness and infection. So this is when they need medicine more than anything. And we'll talk about sick day education later. It also can be that they have not enough medicine, and they may run out of their medicine, or they're not administering it properly, or a lot of times patients, I see this happen fairly often as patients, they save their insulin vials. They're only supposed to use those for about 4 weeks, which we'll talk about, but a lot of times people like they're expensive. And so they're like, man, I'm not throwing this out. I'm going to keep using it. But they might only have to use a couple units a day. And so then to throw that vial out after a month, even though they still have maybe half or more left, it's really hard to imagine. But if it's expired, if it's not working, then they're administering insulin that's not actually effective into themselves. So even though they're trying to use every last bit of this medicine, it's not medicine that's actually still effective. It's expired. Or just general poor management of their diabetes, not taking their medicines in general. So let's do an application check. So a nurse is caring for a client with suspected diabetic ketoacidosis. Which finding is most consistent with this diagnosis? So I'm looking for what is going to be most telltale, or which of these could I alone, based on this finding, say that they are most likely in a state of diabetic ketoacidosis, like based on what information I have. So A says client is sweating and feeling nervous. So there's a lot of reasons a patient with diabetes might be sweating and feeling nervous. That actually sounds more like hypoglycemia. So I can't alone, just based on that assessment finding, say, hey, this is most likely diabetic ketoacidosis. So then we go down to respiratory rate is 10. So really, because I should say, rather than maybe I can't use any of these alone to diagnose diabetic ketoacidosis, but which of these would I expect to find, or which of these would be hallmark or telltale? So if someone had a respiratory rate of 10 breaths per minute, what do you call it? That sounds like what do you call it? Well, they would be possibly in a state of respiratory acidosis because they're not taking a lot of breaths. I don't think it has anything to do with diabetic ketoacidosis, because I think a diabetic ketoacidosis, they actually end up doing that rapid deep breathing, that Kussmaul's, the it's to breathe off that excess acid. So I feel like because there's too much acid in DKA, that they would actually be breathing faster instead of slower. So I don't think that that's consistent. Ooh, now we have an ABG. So let's work this out. So we have a low pH, a normal CO2, and a low bicarbonate. So to look at this, I have a state of acidosis because my pH is low. And then I'm doing arrows in my head. I'm not going to draw it out here. But if I was comparing, I can't compare my pH and CO2 because my CO2 is normal. But if I compare my arrows for my pH and my HCO3, they're both going in the same direction. So if you remember, respiratory opposite, metabolic is the same. So if I have two arrows going in the same direction, my pH and my HCO3 are going in the same direction, which means I have a state of metabolic acidosis. And for those that really, really, really just want to practice ABGs, because my CO2 is normal, it means my lungs have not started to compensate yet. So therefore, I'm in a state of uncompensated metabolic acidosis. Now that sounds a lot like diabetic ketoacidosis. It's a metabolic problem, not a respiratory problem. And they're going to be in a state of metabolic acidosis because of the accumulation of ketones. So this one is the one I like the best, but it says most consistent with this diagnosis. So I need to check all the answers to make sure. So the last one is that it says they're flushed and they have a blood pressure of 156/78. So, the flushed, kind of throws me off a little bit. It makes me want to choose it, but I feel like with this, the severe dehydration, that their blood pressure would actually be low rather than being high. So I don't think that's consistent. So the only one that I think could possibly be related to diabetic ketoacidosis is going to be C, with this ABG of uncompensated metabolic acidosis. So diagnostic testing that's done for DKA, we're going to expect a glucose that's greater than or equal to 250. And again, this can vary, but usually this is around where it's going to be. It could be higher. Their ABG, again, are usually going to show signs of acidosis. So the pH is less than 7.3. Their bicarbonate's usually going to be less than 16. And again, their acid-base imbalance they're usually in is metabolic acidosis. Now, it doesn't matter if it's compensated or not, that the compensation doesn't matter, but what you would want to know is that I'm expecting a patient with diabetic ketoacidosis to be in a state of metabolic acidosis. So remember, if we go back to acid-base stuff, that metabolic acidosis is kidney problems, or in diabetic ketoacidosis, it's where we have too much acid or not enough base, like we're losing too much base, or we have too much acid that we're accumulating. So, the other thing we would find is possibly a positive urinalysis for ketones. In other words, I have all this acid byproduct. My kidneys are going to start to try to get rid of it, but there's too much. So I'm going to be, you're going to notice that in my urine, and that's a very key sign that the action needs to be taken. There is never a time that it's okay for a patient with diabetes to be positive for ketones and not need to take any action. Positive for ketones means dehydration and possible DKA. So I need to start taking action. And then again, like we mentioned before, if I have a whole lot of sugar in my blood, my body's going to try to get rid of it and it's going to come out in my urine. And so I'll have that positive urinalysis for glucose. So what does a patient with diabetic ketoacidosis look like? They're going to have signs of dehydration, like dry mucous membranes, and they might have signs of kind of like that shock-like state where their heart rate is up and their blood pressure is down because there's less volume. So the body tries to compensate because the heart is so smart and so beautiful. Um, and so then they're also going to have signs of hyperglycemia because remember, these are our three problems: dehydration, hyperglycemia, acidosis. So signs of hyperglycemia. So think of like the fatigue and then the three classic symptoms: polyuria, polydipsia, polyphagia, and then signs of acidosis. And that's the Kussmaul's breathing. And again, so this is a compensation. So Kussmaul's breathing, it's not actually a bad thing. So remember, if I have a kidney problem or a metabolic problem, my lungs come to compensate. So if my kidneys are in a state of metabolic acidosis and there's all this extra acid, my lungs are going to say, hey, I can help. And let me get rid of some of this acid. Remember, they can blow off more CO2, which is an acid which can decrease, or should say, it can help to buffer and I don't want to say buffer because I feel like I want to word this carefully. Effectively, my compensation through my breathing can help to get my pH back to normal. So what happens is that remember, CO2 is my acid in my lungs that my lungs can help to get things back into order. So CO2 is an acid. So if I'm breathing faster, I'm going to be breathing off more acid and then getting back to that normal pH balance. So people with Kussmaul's respirations, you'll notice that they're breathing deep and fast. The fast is the more breaths that I take, the more CO2 I get out. The deep is the deeper breaths I take, the more gas exchange that happens, the more CO2 that gets blown off. So it's like, it's a very deep, rapid breathing. And then there's also acetone breath. So my body has all this extra acid. It's trying to get off all these extra ketones. So you actually can smell kind of a fruity breath. Most people think that this is going to smell good, but it can actually smell. It's a very strange smell. Once you'll know it when you smell it. Yeah, it's a very, it's considered to be like a fruity breath that you're going to have. And that's acid that's getting blown out literally through what do you call it? I don't want to say the liquid, but the particles in my breath. It's trying to get some of that acid off. So how do I know this patient's getting better or worse? So I want to look, it really is going to vary. It depends on the patient. Not all the patients are going to have blood pressure issues or etc. But this is what I want to be looking at as a whole. I want their blood pressure to be increasing or going back to normal. Depending on where they were at to start. At least 30 mils per hour of urine output. Now, you might find this confusing because you're like, wait, I thought they had polyuria. But what I mean by this is that I want to make sure that their kidneys are getting good perfusion. If my blood pressure is low, my kidneys also can start to shut down. So I want to make sure that they're getting good urine output or showing that their kidneys are functioning. And that's more related to their blood pressure than it is like the other symptoms that they have. They're also going to be getting better if their blood sugar is decreasing back to normal. And we usually want to do this at a steady rate. It shouldn't be big jumps back to normal. And their mental status improving. They're going to be getting worse if their blood pressure is getting worse, if their urine output's getting worse, showing signs that their kidneys are going into failure. If their blood sugar is increasing, or showing any signs of worsening mental status or decreased level of consciousness. I want to watch, we're going to talk about this. They can have issues with their potassium, which can lead to dysrhythmias, and they can also have kidney issues. So I want to be watching closely for those as a side effect of the DKA. So my priority assessments for these patients are going to be assessing their level of consciousness and mentation, or I'll hear my son, seeing overall how they're thinking or how they're, processing things, because a lot of times when the sugar is just in the blood and it's not where it's it's not in a place where it can actually be helpful to my brain. I can have a decreased level of consciousness or problems, connecting dots and bringing things together. I also want to assess their hydration status because remember, this is one of the main issues is hydration. So look at urine output. This is one of the best signs of how hydrated I am if my urine output is good. Now, again, you have to consider the fact that these patients can have the polyuria, but as a whole, I want to make sure that my kidneys are getting perfused. And we want to look for signs of dehydration. So which I say, such as, so this is where in class I would ask, like, hey, what are the signs of dehydration? So a lot of people will say like skin tinting. I have to tell you, skin tinting is a very late sign that I'm dehydrated. So usually the better ones are, we do look at urine output first, and then the mucous membranes, we can see if they feel dry there. We can look at blood pressure as a sign of hydration and stuff as well, because volume is pressure. Those are going to be some of the best signs of hydration when it comes to it. It's like really looking for those signs that the patient may be dry. Assessing their blood glucose level. So knowing where they're at and what trend or direction that they're going in is going to be super key. And then also assessing for any sort of electrolyte imbalances, like, there's an issue with potassium here, which I'll talk about in a second. But this patient may need continuous EKG monitoring, and then regular monitoring of their electrolyte labs, especially their potassium. I feel like, yeah, I'll talk about the potassium thing here. So let's talk about what we're going to do first. So, per your book and everything, airway patency comes first. And I've got to tell you here, yes, absolutely. If there's an airway issue, they're so asleep, so passed out, they're not even waking up. Or if they're, not breathing well, their oxygenation is low, that's always going to come first. We're going to put O2 on, head of bed up, support that, get them a permanent or temporary airway if needed. But this is not usually the case. DKA is not usually an airway breathing problem. It's usually a fluid dehydration problem is what is most priority. But I do have to put here ABCs because of course they will come first. But just know, 9 times out of 10, like if there was a patient in DKA and it asked like, hey, what's their first priority? And it was between oxygen or fluids is going to come first. Because unless there is an airway or oxygenation issue, the O2 is not going to be what fixes or saves them. Because the one thing you want to keep in mind is this patient, they're going to have that rapid deep breathing. So they may look like they're breathing abnormally or like they're tachypnic, but they're not. They're compensating for their acidosis. That's a good thing. We want them to Kussmaul's breathe. So don't think that necessarily that's a bad sign. But again, we're just going to be looking for, are they not awake enough to keep their airway open, or is their oxygen saturations low? And if that's the case, then oxygen would be the first priority. But otherwise, you should always think your first priority for DKA should be fluid replacement. Because one of the most scary, things for this patient is going to be the possibility is that they could, go into a complete state of like hypovolemic shock, or lack of fluid shock. So fluids first. After fluids, then, we really want to move into getting them the thing that's going to fix them. The only thing that can really fix this patient, they do need to be rehydrated, given fluids, but the only thing that can really fix this patient is going to be insulin. This is what they're missing. This is why they're in this state, is because they have not enough or no insulin in their body. So we give insulin. The only type of insulin you can give IV is going to be regular insulin. It's the most predictable, which is why we can give it IV. But effectively, fluids give insulin in order. That's the only thing, again, that's going to truly fix this problem. We'll probably keep their head of bed elevated just to support an adequate breathing pattern. Electrolyte replacement. So let's talk about the potassium thing. So when a patient comes in, insulin and potassium work opposite as well. When insulin is around, it puts potassium into the cell, like it allows potassium to enter. So kind of like it can allow glucose in, insulin also helps potassium to get into the cell. So if I am a patient that does not have a lot of insulin, you have to think about, what's my potassium going to be in my blood? So if I don't have the key to open the cell to get potassium into the cell, then what happens? Well, then I have a bunch of potassium hanging out in my bloodstream. So when these patients come in, commonly they either have a normal or a high potassium because there's not insulin to get it into the cell. Now, once we give them and start administering, because remember, one of my second priority interventions is going to be that IV insulin. What happens here is they can have a steep, very quick drop in their potassium because all of that potassium that was hanging in the blood starts getting shoved into the cell. And so we need to monitor their potassium closely because, again, highs and lows of potassium, we don't mess around. 3.5 to 5 is that normal. And, if it's too high, that's like lethal injection. If it's too low, it can cause severe life-threatening dysrhythmia. So we have to watch this super closely and make sure that this patient is, not having dysrhythmias, any issues. So ECG monitoring, monitoring that potassium pretty regularly is going to be key. Um, Once a blood sugar for a patient with DKA, and again, most of these patients, they come in the 300 or 400s, it gets below 250. We start giving them the insulin, their blood sugar starts trending down. Once it gets below 250, we start them. We usually have them on regular fluids like normal saline, something like that before this. We change them to D5 half an S. So we want some sort of fluids. It doesn't have to be D5 half an S. It needs to be some sort of fluid that has sugar in it. Because here's the thing, you might be wondering, wait, whoa, hold on a second. You said they had too much sugar. Now, we don't want them to be overloaded with sugar, but when we get less than 250, we don't want them to drop rapidly because it could lead to serious problems. So what we want to do is we want to give them fluids while also giving them just a little bit of sugar to make sure they don't drop too quickly. It's not a ton of sugar, so it's not going to make as much of an effect as you think, but it's just going to help so they don't have such a steep drop. And then if all else fails, if we've done all of this, they've been on insulin drip for a while, their fluids have been replaced, their electrolytes are stable, and their pH is out of balance. Then we may give sodium bicarb. This is just a Band-Aid. It doesn't really help fix the problem. It just helps to kind of give a little bit of an extra buffer against all the acid. Now, 9 times out of 10, we don't have to do this because once, you may think like, oh, how does their pH and everything get back to normal? It gets back to normal when we get glucose back into the cell with insulin drip. So again, you'd be amazed at how regular an ABG can become fairly quickly once we start getting all of that glucose back into the cell. It helps, and then the fluids again dilute and flush out that extra acid as well. So it's a combination of things. And we usually don't have to use sodium bicarbonate, but just know it is an appropriate treatment if we've tried everything and our pH is still way off and we need to get back to that normal balance. All right, so now let's compare this to HHS. So HHS is the same exact process is happening with one exception, is that this is more common in type 2 diabetics. What's happening here is that it's a severe hyperglycemia which leads to dehydration. So the thing that compared to DKA, this is the exact same thing that's happening. The thing that's missing here is that I still have some insulin because I'm type 2 diabetic. I still have some insulin. And so I don't get to the point where I'm breaking down fat into ketones. So there's no fat breakdown, there's no acidosis. It's just a lot of sugar, and that sugar is leaching my fluid and causing a severe dehydration. So these patients just have high blood sugar, severe dehydration. There's no acidosis, there's no ketones, none of that's going on. It's just down to too much sugar, not enough fluid. It's the same process here. I have a lot of sugar. The sugar pulls all the water from my cells, and then the body gets rid of the extra water through the kidney. So I get this massive dehydration and all the sugar still in the bloodstream. It has very similar causes, a new diagnosis of type 2 infection or illness. And it's also, you're going to see more common in those that are older and those with an infection, especially those that are older with an infection. So the other differences you're going to see here is there's no signs of acidosis, nothing acid related going on here. So there's no ketones, there's no change in my pH or ABG abnormalities. The things that you might notice is that there is a blood glucose that is usually above 600. So it's a lot higher compared to type 1. And a lot of that just has to do with the fact that patients with type 2 diabetes can get their blood sugar pretty high before they start feeling the symptoms of it. And because they still have some insulin, so their body's, it's making it through even though it's not doing well. The other thing that we're going to notice is that they could have what's called an increased serum osmolality. So this measures how many particles are in the blood. So normally you can kind of see like in this picture, normally there's just like these little white particles. They're evenly dispersed. Now, when you have a whole bunch of extra particles, all this extra blood glucose, there is a test called a serum osmolality, which measures how many particles are in the bloodstream. And for this patient, you're going to see that there's a whole lot of particles, like that number is going to be higher. And so that's pretty much telling you there's a whole lot of particles and not enough particles in comparison to the amount of fluid that is in my blood. You do not have to know the normals, at least where I go, or where I teach, I should say. I always wondered what it would be like to go back and be a student, but then I remember how painful it is, and I don't want to do it. So, I'm praying for all of y'all. You're gonna be fine, by the way. But yeah, I do not. There's times that I miss it, but then I think about it and I'm like, oh no, it's so painful. So yes. But just know that on the teacher side, it's still a lot of work, and writing test questions feels like being a student where I want to cry sometimes. But anyway, moving on. What does this patient look like? So this patient's going to look just like the patient with DKA, except they don't have any of the signs of acidosis. So they're still going to have the signs of dehydration, same stuff, increased heart rate, decreased blood pressure, dry mucous membranes, and then signs of hyperglycemia. And so that's going to be, and I should note the one thing that is different when it comes to symptoms is because their blood sugar gets so much higher, they usually have a more profound change in mental status. So what you're going to look for DKA, you're going to look for the hallmarks of those signs of acidosis, that Kussmaul's respirations, and the acetone breath, stuff like that. Whereas for a patient with HHS, you're really going to focus on that mental status. Where a patient with DKA, they can have changes in mental status. It's usually just more profound and severe in HHS. And then again, the signs of hyperglycemia, that polydipsia, polyuria, and polyphagia. So how do I know they're getting better and worse? This is going to look exactly the same as it is with DKA. The one thing I guess I could have mentioned with DKA for getting better is that their ABG is improving and things like that too, but which I didn't mention that, but maybe I'll have to add that. It's going to be looking the same here. Like I want them to show signs that they're hydrating and that their blood sugar is getting back to normal and their mental status is improving. And again, it would be the opposite for if it's getting worse. The only thing I want to add here is that they can have more severe neurological complications as a result of their blood sugar being so high. So that would be like seizures and coma. So I want to watch closely their mental status for seeing how things are getting better or worse. So priority assessments for these patients. We are going to, like I mentioned, really focus in on that level of conscious mentation, as it can be severe and very dangerous. How low and I was going to say low and slow it can get. We also really want to watch the hydration status, the urine output, those signs of dehydration we talked about, their blood glucose, and then the same stuff with the potassium. Now, I will say that usually with the HHS, they have less of a profound shift with the potassium because, again, they still have some insulin, but they can still have the same problems where they come in really high, and then with the insulin drip, they get low. So this is going to look exactly the same as the treatment for DKA. The only difference here is there's no treatment for the acidosis. We do not use sodium bicarb for HHS, as it will have no effect, as there is no acid-base imbalance. It's not an acidosis problem. This is just a dehydration glucose problem, whereas DKA is an acidosis dehydration glucose problem. So fluid replacement first. Again, if there's an airway oxygen issue, we'll take care of it. And these people might be more sleepy, so we might need to protect their airway a little bit. Might be a little bit more high risk for airway issue. But as a whole, fluid replacement, IV insulin drip, regular insulin only is the only one can give an IV. Head of bed is going to be elevated. If we need to give that electrolyte replacement or do ECG monitoring, we will. And then once the blood sugar is less than 250, switch to something with dextrose in it so that their blood sugar doesn't go too low. Okay, so let's do one of these fun NGN questions. This one says, a nurse is caring for a client who is newly admitted to the hospital with HHS. Their most recent blood glucose was 749. So for each prescription, please write whether it is appropriate, contraindicated, or unnecessary for the acute treatment of their illness. So this is one of those where we have to decide if it's appropriate, like it's going to help to advance their goals. If it's contraindicated, aka it can hurt them, or unnecessary, which means it's not going to hurt them, but it's not going to help advance their goals for, and again, it's talking about for the acute treatment of HHS. So my first prescription is going to be a BMP every 4 hours. So I have to think about this. How is this going to help? So a BMP is like a chemistry. So this is going to tell me my kidney function, my electrolytes. So I think that this would be appropriate because I need to keep a close eye on my potassium. And I want to watch closely also with the dehydration, my kidney function. So I think that a BMP every 4 hours, I think that would be appropriate to make sure that they're not having life-threatening changes to their, especially their electrolytes. So I'm going to say A for appropriate for the first one. There's also continuous ECG monitoring. So for this, again, kind of like going with the last one, they can, even though HHS doesn't have as much of usually a profound problem with potassium, they still have the potential for it. So I'm going to say yes for continuous ECG monitoring, especially also because these patients are less awake. And so I might need to watch closely to make sure that they're not having some other issue. Then there's regular diet. Now, this patient's acutely admitted for HHS, which is where their blood sugar is really high and they're on an insulin drip. So one thing I didn't talk about in the actual presentation is that with these people, they're usually, until we get them through the crisis, unless it's a prolonged long-term issue, they're usually NPO. If we give them food, it's counteracting everything that we're doing. Most of the time, one, I'll tell you, these people usually don't want to eat. They feel too sick. They are very exhausted, and they're not very awake, so it might not even be safe for them to eat. But especially their blood sugar is 749. I don't know how awake this person is. It's probably not safe. So I would actually say for this, it's not that it's unnecessary, but I would say it's contraindicated. Giving them a regular diet could cause their blood sugar to go up even higher, and they could, if they're not very awake, aspirate other things. So I'm going to say it's going to be contraindicated or C for now. So I have C so far. Point of care glucose every 1 hour. Well, what's the priority treatments for this patient? They're going to be getting fluids and then also receiving insulin. With that being said, insulin definitely, receiving insulin. Being on an insulin drip does require really frequent glucose checks because they can have severe drops, and I want to make sure that the insulin drip is actually working. Checking their blood glucose every hour, that actually sounds very appropriate. So I'm going to say appropriate. The next one says insulin subcutaneous ACNHS, and ACNHS means before meals and at bedtime. So do I think they need their insulin, ACNHS, like before meals and at bedtime? Well, if I give their insulin just before meals and at bedtime, and if I give it subcutaneous, they could get significantly worse. What do they need? They need insulin regular, and it needs to be given IV, and it's continuous drip. So I would say that this is, you could really say either. I would say it's more, because if I give this, it's just not going to really help advance their goal. So it's kind of, this is a hard one. I don't know why I put this one in here to make my life so difficult. But I would say that it's probably contraindicated, because it could cause harm because it's going to lead them to stay in their state of HHS for a lot longer. All right. So now their blood glucose is 749, and my next order is D5 half an S at 100 mils per hour. So is this an appropriate order in general for a patient with HHS? Absolutely. But is it appropriate right at this moment when their blood sugar is 749? The answer there is no, it's contraindicated. If I give this right now, their blood sugar is going to go up even more, which is not going to help them to get back to a state where they are hydrated and they're getting back to a normal blood glucose. So that one is contraindicated. Then I have labs, total cholesterol, HDLs, and LDLs. These are cholesterol labs. Now, I want to check cholesterol labs in a patient with diabetes, but while they're in an acute crisis and their blood sugar is so high, is this really necessary right now? I'm going to say Okay, did that really well. For unnecessary. This is like a C, so I'm gonna have to make it like a U. And I have fat fingers, so unnecessary is what I'm going to say for that. Um, then we have, because again, I mean, this is something we're going to check sometime, but do I need it during the acute treatment for the acute treatment of HHS? No, it's not going to change my care or do anything for my care. Then I have cefazolin, which is a antibiotic. So they might have something else going on, but antibiotics are not a treatment for HHS. It's not going to advance my goals or help their blood glucose necessarily. Yes, if they're sick, it might help treat their infection, which could lower their blood glucose, but it's not used to actively, in this moment, acutely bring their blood sugar down. So I'm going to say it is unnecessary. Does that mean I'm not going to give it? Or does that mean, again, that I'm not going to get these labs? No, but it's not going to be top of my priority list right now to acutely treat. The point of this question is not to say like, what is okay or not okay to do, but it's really trying to prioritize or have you look at what's most important for me to check or to do right in this moment. All right. So that is it for acute complications. That was DKA versus HHS. We're going to move into chronic complications next. See you for the next one.